Okay, so block 3. This is the actual block 3 of NBME 22. I broke all the videos up into 20 questions of video this time around because it was really overwhelming to do more than that, and I didn't really want to rush any questions. It also gives me some time to take questions during the live stream. As usual, keep in mind any page numbers I have written here, I usually write 2 page numbers anytime I do reference anything like this. So the first one is the actual first day 2019. The second number, 605, that's the page for my own annotated version. So right now, we're up to question 101 of NBME 22. So let's just jump right into it. Let me see. Okay, so a 54-year-old woman with hypertension and bilateral renal artery stenosis, right? Very high-yield topic. Renal artery stenosis starts taking a non-steroidal anti-inflammatory drug for back pain. Over the next week, her serum creatinine concentration increases from 1.0 to 5.0. The most likely cause of this finding is the drug's ability to inhibit which of the following? All right. So on NBME, renal artery stenosis is actually one of their top few favorite topics. You will definitely, without a doubt, always have a question on renal artery stenosis in one way or another on your NBME. So this woman, she started taking some NSAID. You have to remember how NSAIDs work, what the impact of NSAIDs are on the kidney, right? So let's take a look at that in first aid. 577 is the actual page number. Hold on, let me see. Okay, so right here you can see, right, prostaglandins, right? NSAIDs block renal protector prostaglandin synthesis, leading to constriction of the afferent arteriole and decrease in GFR. This may result in acute kidney injury in low renal blood flow states. And that patient is in a low renal blood flow state because she has renal artery stenosis. So how do you memorize this kind of stuff? So let me see. Earlier, right here on this page, right, they tell you what NSAIDs do and what ACE inhibitors do. So remember that ACE stands for angiotensin constricts the efferent, right? ACE. ACE inhibitors, angiotensin 2 preferentially constricts the efferent arteriole, right? That's what ACE do. That's what ACE itself does. If you take ACE inhibitors, you stop that, right? So you no longer allow the efferent from being constricted. But in general, when ACE itself does do constriction of the efferent arteriole, that constricts the exit, right? It constricts the exit arteriole. So blood stays in here, and you have more GFR, right? That's the general concept there. Prostaglandins, you want to think of PDA, like right up here, right? So this is the memorization tool I'm talking about. PDA, so prostaglandins dilate the afferent. So that means that you dilate the arrival artery, right? So more blood comes into the glomerulus, and that also increases GFR. Both of those are 2 different ways of increasing the GFR. If you take NSAIDs, you prevent this, right? You stop the entire afferent arterial dilation, which would really suck if you already had difficulty bringing blood into the kidney. And in our patient, they tell you that this patient, this woman, she has renal artery stenosis, which means that her kidney really isn't getting enough blood as it is anyway. So now they want to know the most likely cause of this finding is the drug's ability. They're basically just asking a very straightforward question about the mechanism of action over here. So the drug's ability is in vasodilating prostaglandins, right? And you want to pick prostaglandins at the, why is this F? This should be E, right? Yeah, my bad. Typed the wrong thing here. Yeah, E. Right, because prostaglandins, they go ahead and dilate the afferent arteriole. So always remember that the PDA thing and the ACE, those 2 things are very high yield, very easy to remember, not the most difficult thing. And then understanding this table, changes in glomerular dynamics. I did this in my newer renal videos already, and I added some of the other things that weren't here in your original first aid book. Very easy to understand this stuff, okay? Always keep in mind that GFR is all about how much blood, how long you keep blood in here, right? The longer the blood stays within the Bowman, within the glomerulus area, the more filtration you have, right? Because this is where filtration is happening. This is everything being filtered. Then you either reabsorb or secrete things, and finally end up excreting in urine whatever you decided not to keep. Right, so that's your prostaglandin question. Really straightforward stuff. This one, they gave you a very good picture of schistosoma, basically, right? And they tell you a very good, clinical scenario here too, which is why I really liked NBME 22. It's a good test compared to most other NBMEs. NBME has a high tendency of just giving you like 2 sentences and then a very bizarre image or something. But in this NBME 22, they did a really good job giving you the right images, the right clinical scenarios, and good answer choices. So a 12-year-old girl who recently immigrated to the USA from Central Africa is brought to the physician because of a 5-week history of increasingly severe abdominal pain and vomiting blood. Temperature is 100 F, pulse is 110 per minute, respiration is at 27 per minute, and blood pressure is 112/65. Physical exam shows hepatosplenomegaly and abdominal ascites. Lab studies show a leukocyte count that's pretty much normal on the upper end. Segmented neutrophils 42, eosinophils, lymphocytes 37, and monocytes 6. Photomicrograph of a stool specimen is shown, which of the following is the most appropriate pharmacotherapy for this patient. So you look at this, right, and this is discussed on page 165, so let's take a look at where the rest of those images are in the book. So that's 160 of your actual first aid. Right here, right, the spine is the giveaway, right? So these are the images the book gave you, A and B over here. A for the lateral spine of S. mansoni, and B for the terminal spine of hematobium. And then I have a couple more pictures of the same stuff. You have Mansoni with the lateral spine, right? Hematobium with the terminal spine right in the middle, very symmetric. There's also Schistosoma japonicum. This has a sort of a lateral spine too, but it's not as pointy. It's a very nubby little spine. What does this do? So you're going to see liver and spleen enlargement, right? Fibrosis, inflammation, and portal hypertension. Okay, and that's S. mansoni. Snails are the intermediate host. That was an answer choice in the UWorld question regarding this. Cercaria penetrates skin of humans in contact with contaminated fresh water, either in swimming or bathing. And then here is just the basic immunology of understanding what happens. You get a periportal pipestem fibrosis, which leads to portal hypertension, right? So that's the entire pathophysiology of what's happening to this patient, which is why she's presenting the way she is with abdominal pain and vomiting blood. That's portal hypertension. And here the treatment would just be D, praziquantel, right? That's it. Metronidazole, levofloxacin, fluconazole, and trimethoprim are completely irrelevant here. If you did the sketchy micro image, right, then you remember the praziquantel because praziquantel is a pretzel, and they have the pretzel pretty much all of it. All these guys here are using the pretzel to treat it because you basically use praziquantel for tetansolium, diphyllobotium latum, right, and then all of these guys, schistosoma, chlamynarchus. Okay, so very important to remember that, and you should also remember the other antibiotics and other medications that are listed here are used for completely different things. So make sure you know what those are for as well. Okay, so not so bad, very good picture. This one, 38-year-old man who lives at sea level flies to a mountain resort in Colorado for a skiing vacation. He takes a carbonic anhydrase inhibitor tablet after arriving at the resort to help adjust to the altitude. 2 hours after drug ingestion, which of the following changes in urinary pH, bicarbonate, and volume are most likely in this patient? So this question is less about the altitude part and more about the carbonic anhydrase he took, because the altitude part is going to take a very long time for the patient to have any changes. But the carbonic anhydrase, they gave you enough time, 2 hours after ingestion, so the medication has definitely started taking effect. Carbonic anhydrase, you have to remember the mechanism of action, so you look at all the answer choices, and this is the explanation right here. Since you're losing all your bicarbonate into your pee, you would expect the pH to be more alkaline. Also, since there is decreased sodium hydrogen antiport, there is less sodium reabsorbed and therefore increased loss of free fluid to the urine. And this one, as soon as you saw answer choice A, you would just pick it. Right? You just needed to know how carbonic anhydrase inhibitors work. So let's take a look at those real quick in renal form. Right, we go to carbonic anhydrase inhibitors, so that would be your acetazolamide, right? And you have to remember acetazolamide, it doesn't, I didn't really always like this memorization mnemonic because it says acetazolamide causes acidosis, but that's not true per se. Clinical use is for metabolic alkalosis, right? And it alkalinizes the urine, and that's the part that you really need to remember, right? Acetazolamide does cause metabolic acidosis, but the thing you need to remember is based off of the mechanism of action of acetazolamide. By inhibiting carbonic anhydrase, it causes self-limited sodium bicarbonate diuresis. Basically, the whole concept is acetazolamide makes you lose all of your bicarbonate. That's how it causes the acidosis. Right? And then because you cause acidosis, some of these adverse effects are all related to that. Right? So proximal renal tubular acidosis, calcium phosphate stone formation, right? Promotes calcium phosphate stone formation, insoluble at a high pH, right? So this thing is also kind of hard to remember if all you think about is acetazolamide causes acidosis, because remember when we talked about the stones, right? We said any stone that has phosphate in it, phosphate, when you write the word phosphate, it has pH twice, which means that to make a phosphate stone, calcium phosphate, any other phosphate stone, to make a phosphate stone, you need your urine pH to be high, alkalosis in the urine, right? And that's the one you really want to remember. So try your best for acetazolamide to make sure you remember that it alkalinizes the urine. And off of that, you can obviously deduce that it's going to cause acidosis, okay? But once you remember that it alkalinizes the urine, of course your urine pH is going to be very high, so you make a lot of phosphate stones. Okay, or you're at a higher risk of making phosphate stones. But basically, they wanted to know, changes in urinary stuff, what happens to the urine, and if all you think of is acetazolamide causes acidosis, right, then you can pick the wrong answer choice here. So that's what I'm trying to make sure you guys don't mess up right there. Right, so this is page 594 and 662. All right, so make sure people tend to remember that acetazolamide causes acidosis, but it's more important to recall that acetazolamide alkalinizes urine, predisposing patients to phosphate stones. Right, and since you remember it alkalinizes urine, you can see even this question is about the urine, not what's happening to the patient per se. So in the urine's pH is going to be very high, and you can immediately knock out half your acid choices, E, F, G, and H. Right, and then what's going to happen to urine bicarb? Well, the reason your urine pH is so high is because you have a lot of urine bicarb, right? And acetazolamide increases volume of urine too. You pee more. Okay, so very interesting medication, very useful medication, especially in patients who have metabolic alkalosis. You can help them lose all of it. If you have altitude sickness, which is why that patient was taking it, and an idiopathic intracranial hypertension. The glaucoma use is a different thing, right? So the aqueous humor, remember that aqueous humor is produced by non-pigmented epithelium on the ciliary body and is decreased by beta blockers like timolol, alpha-2 agonists like brimonidine, and carbonic anhydrase inhibitors like acetazolamide. That's if you want to decrease the production of aqueous humor. Okay, here, 45-year-old man with poorly controlled type 2 diabetes comes to the physician because of a 1-month history of low-grade fever. He is receiving hemodialysis for end-stage renal disease. His temperature is fine, pulse is okay, blood pressure is high. Physical exam shows a subclavian catheter inserted below the right clavicle. The lungs are clear to percussion and auscultation. Cardiac exam shows no murmurs. 2 of 2 blood cultures grow non-hemolytic, catalase negative, gram-positive cocci in pairs and chains. Which of the following is the most likely causal organism? So they described the organism though, right? They described it. They tell you it's non-hemolytic, catalase negative, gram-positive cocci in pairs and chains. There aren't that many gram-positive bacteria that you need to be very good at. So since it is gram-positive, you look at all your answer choices, and Enterococcus faecalis was the best answer to go with. Listeria is a rod. Staph aureus has a cat in it. It's catalase positive. Staph epidermidis also has a cat in the sketchy microimage. It's catalase positive. Strep pneumo has hemolysis, right? So remember strep pneumo and sketchy micro, it was the alpha night tournament between strep pneumo and strep viridans, so they're both alpha hemolytic, right? So the description they gave you was more than enough. You didn't even need the rest of the clinical scenario to be able to pick Enterococcus faecalis as the answer choice. A 2-year-old boy is brought to the physician because of fever and cough for 2 days. He has had 2 episodes of streptococcus pneumoniae, bacteremia, and multiple ear and sinus infections since birth. His temperature is 101.1, so that's high. Physical exam shows no tonsillar tissue. Crackles are heard in the right lower lobe of the lung. Which of the following is the most likely immunodeficiency syndrome in this patient? So the main thing was they told you that the physical exam is always very critical, and they tell you physical exam shows no tonsillar tissue. That was the big clue here. Total lack of IG, which causes recurrent infections after 6 months. Once the maternal IG is gone, LN and tonsils are minor or non-existent. Right? Lymph nodes, no tonsillar tissue. This was A, Bruton's agammaglobulinemia. So let's take a look at that in the book real quick. I believe that's also in immunology. Let's see. Let me see, Bruton. Click. Yeah, right. So this one right here. So defect in the BTK, which is, I always think of this as bad tyrosine kinase, BTK, right? A tyrosine kinase gene. There's a defect in it, and the B also reminds you of B cell. There's a defect in B cells, recurrent bacterial and enteroviral infections after you run out of maternal IgG. Right? You're going to have absent B cells in peripheral blood, low IG of all classes. No IgG, no IgA, none of that. Absent or scanty lymph nodes and tonsils, right? It's given in the book, and that's exactly where they took it from. Because these guys don't have any of that, you cannot give them live vaccines. Right? So this is the presentation, which you generally see, and that's exactly what we saw in our patient in our question 2. All right, not so bad. This was... Okay, so yeah, NBME really enjoys giving electron microscopy images and really interesting CT images. So you do have to be pretty good at being able to see anything that doesn't look like it should be there. This is an interesting way of testing you on this stuff right here. So I found this picture online, put it here because it's pretty relatable. You can see the cartoon version of everything you're seeing here, basically. So microelectrode injection of antibodies to alpha-actinin results in detachment of the myofibro from the plasma membrane and cardiac myocytes. On the basis of these data, alpha-actinin is most likely located at which of the following labeled sites in the electron micrograph of a normal cardiac myocyte shown. So, when you read this, you might be like, what the hell are they talking about, right? What is actinin? And whatnot and whatnot. They're introducing a bunch of weird things. And then not only that, by the time you were done reading this question, you really didn't know what they're, if you didn't know what they're talking about in terms of detachment and why something would detach, then looking at the image would only further confuse you. Now, when you look at the image, it's really easy to say that the answer most likely is not A or D, because A and D are both just pointing at completely dark areas, right? So most likely whatever happened didn't happen inside one of those, but at some point where something was connected to something, right? Because the question is about detachment. Area C, which was the answer, area C is where the gap junctions between cardiac myocytes are. Gap junctions are found on the plasma membrane of the cardiac myocyte. The question is basically asking where the plasma membrane is with a bunch of biochem mumbo-jumbo you don't have to understand, okay? So if you look at the cartoon image, right, you can see your gap junctions right here. Right, this is what's kind of connecting different myocytes. And that's what you're seeing right here. This is a connection of 2 different myocytes. Right? Everything else is solidly connected. There's nothing to basically unzip. Whereas this portion here does look like a zipper. It does mimic a zipping kind of activity that's occurring here. Okay. And the alpha-actinin thing that they used was basically unzipping this, causing a detachment of cardiac myocytes from each other. That's all it was. It was a pretty weird question. Not exactly the best way to ask it, per se, but, it makes a point and it teaches you pretty silly stuff, though. 82-year-old woman has been bedridden since surgical repair of a hip fracture 6 months ago. So right there, you want to already start assuming a bunch of things. One, she's super old, right? And because she's been bedridden, there's a lot of stasis, okay? Then you move on. Healing has proceeded slowly, and her physician is concerned that DVT may develop, which is what you should have thought of too because of all the stasis. A drug that suppresses the action of which of the following factors is most likely to decrease the patient's risk for thrombosis? Right? So basically, you just need to know which one of these things are related to thrombosis. Now, what would you give to a patient who needs to be on long-term anticoagulant therapy? Once you think of that, you're done with the question. If you don't think of that, then maybe, when you start looking at all your answer choices, you start considering what each one is related to. And a drug that suppresses this would be warfarin. Warfarin is what you give patients for long-term anticoagulation, and A would just be the answer. Warfarin inhibits vitamin K-dependent synthesis of factors and proteins. Vitamin K is necessary for the maturation of clotting factors 2, 7, 9, 10, CNS. So a drug that can inhibit the carboxylation of precursor proteins, or in other words, inhibit the maturation of clotting factors, will decrease thrombosis risk in this patient. Right, that was all this was. It was a very straightforward warfarin question. Nothing confusing at all. Really no reason for you to pick nitrous oxide. You definitely don't want to inhibit protein C and S because these guys are anticoagulant. Right? They stop coagulation. They cut and stop. CNS cut and stop these factors, 2, 7, 9, 10. Mainly 5 and 8 for the most part is what you want to think of, but just for memorization purposes, I usually say it like that. Thrombomodulin was irrelevant, and prostacyclin was definitely irrelevant as well. All right. So again, not a very difficult question. When it comes to warfarin, always keep in mind that you have to start a patient with heparin therapy first. Why? This is where the lifespan of all the factors plays a major role. Factor 2, I always think of as step 1 is too long. Factor 2 has the longest half-life. So factor 2 dies last. Protein C has the shortest half-life. And I just told you that protein C and S are anticoagulant. Factor 2 is a clotting factor, so that's obviously a coagulant. If you get rid of protein C and S with warfarin, and factor 2 is still around, you're going to have too much coagulation that's not being checked, and then you get warfarin-induced skin necrosis. If you start a patient on heparin, heparin's job is to kill factor 2 first, right? And then you can bridge them. That's what's called a heparin bridge. And then you slowly bridge them towards giving them warfarin, right? So that's a very important oncology, pathophysiology when it comes to the pharm aspect of things. Always keep that in mind. Don't fall for silly questions. Heparin-induced thrombocytopenia and warfarin-induced skin necrosis are both topics that you are definitely going to see on your step 1. And they're both topics that do show up on NBME as well. So now here, 42-year-old man comes to the physician because of numbness and tingling in both legs for 2 weeks. Sensation of vibration is decreased in the lower extremities and feet. Deep tendon reflexes are decreased in the knees and ankles. A Romberg sign is positive, right? So Romberg sign, you have to keep in mind what that tells you. Which of the following is the most likely cause of these findings? Okay. So the description of bilateral lower limb loss of vibration implies DCML damage, and the absent deep tendon reflexes plus the Romberg sign seem to me to be implying that he possibly has tabes dorsalis from syphilis, right? Because Romberg sign basically is like you're not being able to stand straight with your eyes closed. As for the other answers, A is wrong because his motor function is intact. B is wrong because pain and temperature deficits are not mentioned, right? Corticospinal tract is a descending tract for motor function. Spinothalamic senses heat and temperature. This is something you see in syringomyelia being damaged. C is wrong because it implies a specific nerve is entrapped, but he lost bilateral sensation in his entire lower limbs. D is the trickiest answer choice that a lot of people would fall for, right? Radicular neuropathy affecting the anterior lumbar roots. However, radicular neuropathy usually presents with just pain. Not always will you have a weird bilateral loss of sensation of vibration. Right? That's not exactly what you see, and it's also less likely. They didn't really give you a major, thing in the question for you to be able to pick radicular neuropathy. You might also expect that motor dysfunction to be unilateral, since it would be unlikely to have a problem with the nerve roots on both sides, right? Radicular neuropathy is almost never bilateral. It usually impinges on one side. Right, so sensory neuropathy was the correct answer choice here. Right, basically by process of elimination, sensory neuropathy is an extremely vague answer though, but that's just what happens. On NBME, they love giving you vague answers, and NBME 22 so far really hasn't had many vague answer choices. They've been pretty good. Right, but 42-year-old man presenting with these kinds of neurologic symptoms is just a sensory neuropathy. It could be something else too. It could be maybe he's diabetic and he's got diabetic neuropathy that's affecting that area. And it could be anything, to be honest. They didn't give you much to work off of in this question, but you just go with whatever seems most likely and most plausible. An obese 45-year-old woman with type 2 diabetes, hypertension, dyslipidemia, and osteoarthritis of the hips and knees begins taking Orlistat and starts to follow an appropriate diet and exercise program. During the first month of therapy, this woman is at increased risk for developing which of the following conditions. Now, if you don't remember Orlistat, there's always a really nice story for that. If you go on Google and you search for Ali, A-L-L-I, that is the name by which Orlistat was actually sold in America when it first came out, A-L-L-I. And Ali was a medication that people were, marketed heavily on TV. You could just pay for it at any pharmacy and buy it. You didn't need a prescription. And what Orlistat basically did was that you could eat whatever you want. They marketed it so nicely. You could eat whatever you want, and all the fat that you eat will just come out in your feces. You're not gonna absorb any fat whatsoever. And people were like, wow, so I can go be a fat ass, eat everything I want to, but my body won't absorb it, so I lose it all. People who were using this long term were abusing it in a sense, right? Because they're like, all right, man, I took my elite today. I'm going to eat all the fatty shit because I feel good. And they would do it, and of course it worked. It worked for the most part. But if you're not absorbing any fats, then you won't absorb any fat-soluble vitamins. And that's what Ali did to people, Orlistat. So if you're not absorbing fat-soluble vitamins, usually questions are going to be about the fat-soluble vitamin loss. You're going to look for someone who has some kind of symptoms of vitamin A, D, K, E loss. However, the other side effect is obviously diarrhea because you're not absorbing lipids, right? So that causes a change in your fecal construction, I guess, right? So what's in your poop will be altered, and that can lead to diarrhea. Anaphylaxis is irrelevant here. Blood pressure was not affected, the heart was not affected, and your tricuspid valvular insufficiency was also completely irrelevant. So Orlistat is discussed here as well. I think it's in Cardiovascular Forum where they talk about statins and stuff. No, not here. Let me see. Orlistat. Or is it in... It might be in GIT. Yeah, so GIT. Alright, so you can see Orlistat inhibits gastric and pancreatic lipase, decreases the breakdown and absorption of dietary fats, mainly used for weight loss. Yes, it works for weight loss, but as anything you use for weight loss, you need to use it with a modified diet and workout regimen, right? You don't just take the Orlistat and continue living life like the pig that you've been living it as, right? You got to change your eating habits, you got to change your workout standards, and then also obviously take Orlistat. Now, of course, you can get abdominal pain, you can get flatulence, you're going to have weird bowel movements and steatorrhea, which is the main mechanism of action, basically. And you end up ultimately, without knowing, decreasing absorption of fat-soluble vitamins. And the general public doesn't really know the difference between fat-soluble vitamins and water-soluble vitamins and stuff like that. So they don't even notice. Eventually, they start having symptoms of vitamin E deficiency, hemolytic anemia, demyelination of their, nervous system, and then they start presenting with weird symptoms, and they're like, what's wrong with me? And depending on the age and the actual dietary lifestyle of the patient before they started taking Orlistat, symptoms can show up really early, and they can just have a very weird presentation that you might not really expect. It's a very interesting medication. Step 1 definitely likes it. It's very usable for testing people on fat-soluble vitamins. So let me just put that in. Where's that page? 394. Okay. Okay. So this is a snippet from Pathoma. Right? It's a very, very important concept to know. 84-year-old woman comes to the physician because of a 2-month history of a sore on her left hand. Physical exam shows a red, scaly, raised plaque on the dorsum of the left middle finger. The diagnosis of squamous cell carcinoma is made. The ability of this tumor to invade the basement membrane is most likely facilitated by which of the following things? And then you get all your answer choices. Now, tumor invasion and spread, right? Heavily related to E cadherin. You look at answer choice D, and you just pick it. Okay, and that's really all there was to it. Right? They tell you accumulation of mutations eventually results in tumor invasion and spread. Epithelial tumor cells are normally attached to one another by cellular adhesion molecules like E-cadherin. Downregulation of E-cadherin leads to dissociation of the attached cells. Now, cells attach to laminin and destroy the basement membrane via collagenase. Cells are also able to attach to fibronectin in the extracellular matrix and spread locally. Entrance into the vascular and lymphatic spaces allows for metastasis. All of these are answer choices. E-cadherin can be an answer choice. Laminin and fibronectin, those guys can be answer choices. You're just going to know this basic concept of pathology. Very important to know. Right? Decreased apoptosis is not the answer for how it metastasizes. Right? Invasion. Decreased apoptosis is the cancer. You have too much. You have no apoptosis, so you have too much reproduction of cells. Decreased laminin is wrong. Laminin doesn't decrease. Laminin is there and it gets used. Decreased production of collagenase was completely irrelevant. And then HER2 new overexpression, this isn't about the estrogen receptors at all. So that's not what the question was relevant to. Right, so now here, all right, so that's half of it. Now here we have, I found this picture to kind of explain this, but this is a concept you really need to know from videos or my video or anything else you can use to master it. A 56-year-old man with a palpable hard nodule on the prostate has an increased serum PSA concentration. A fine needle biopsy specimen shows adenocarcinoma, right? So prostate cancer. The patient undergoes radical prostatectomy. Which of the following structures is at greatest risk for injury during removal of the prostate? Right. So then you look at all the answers: dome of the bladder, obturator nerve, pelvic parasympathetic nerve, penile urethra, ureterovesical junction. A lot of people wanted to pick ureterovesical junction too. Right? And you remember how the prostate is, right? It's right there. It's at the end of your bladder, and then you have the urethra and whatnot. Look at all the nerves that are coming, right? You have your inferior hypogastric plexus coming this way. You also have your sacrosplanchnic plexus coming from up there, right? A bunch of parasympathetic nerves, and all of them are at risk of getting injured when you do a prostatectomy. Okay, those parasympathetic nerves are the purple ones right here, coming from the sacral area, right, which is your inferior hypogastric plexus. You can also injure the other guys too. The sympathetic preganglionic stuff, those are also possible to injure, but less likely. But either way, you got to remember that. Pelvic parasympathetic nerves. Now, this is actually discussed in first aid quite a bit in reproductive. Right? So if you look at penile pathology, right here, right? Benign prostatic hyperplasia, prostatitis, and prostatic adenocarcinoma. The prostate cancer spreads via prostatic venous plexus. The venous plexus. Always keep that in mind. The veins are the ones responsible. Which goes to the vertebrovenous plexus and runs up the entire spinal column to connect with the brain via a valveless system, allowing bidirectional flow to regulate intracranial pressure. This explains why prostate cancer can cause lower back pain and even go to the brain. Now, the prostatic venous plexus is the other thing that you want to make sure you keep in mind, because that's also often tested. UWorld also had a question where the answer was the prostatic venous plexus. Okay, and as far as the nerve part, I think that's in the anatomy area. Let's take a look. Not that. Let's see what's here. So you're looking at, oh, right, this is showing you the pudendal nerve and the inferior hypogastric plexus, both of them, yeah, coming down, right, sacrosplanchnic nerves, all the nerves that are coming down. This is a UWorld image where they kind of showed you the pelvic autonomic nerves and how everything comes down and ultimately goes to the penis. You really need to make sure you remember the relations of the pudendal nerve and all the other nerves that are in that area. They often get tested, especially if you get questions about this stuff. Innervation of the sexual response, right? So your parasympathetic nervous system is very important for erection, right? The pelvic splanchnic nerves from S2 to S4. So if you do a prostatectomy and you mess those nerves up, the patient will no longer be able to have erections, right? Emission is sympathetic, right? That's sympathetic hypogastric nerves from T11 to L2. And then expulsion is just a visceral somatic thing that comes from pudendal nerve. So injury to any one of these three things can cause sexual dysfunction in a patient, right? If you can get an erection but you can't have expulsion, that's also sexual dysfunction. All of those things classify under the same kind of issue, you want to make sure that if you get any of that, right, you should be prepared. So make sure you know those nerves. All right, let me see. Let me put this here too, just for explanation purposes. All right, but yeah, that's the stuff you need to make sure you have down. Male reproductive anatomy, page 612. Okay, so now next one. 60-year-old man is brought to the emergency department because of the sudden onset of pain on the right side of his chest following a deep cough. Right, so deep cough causes sudden onset of pain on the right chest. X-ray of the chest shows a fractured rib, and the bone scan shows multiple osteoblastic lesions distributed primarily in the lumbar spine, pelvis, and ribs. A complete blood count and results of chemistry profiling, urinalysis, and protein electrophoresis are all normal. Okay, which of the following is the most likely diagnosis? Well, osteoblastic. Remember, yesterday we actually saw. Man, I wonder what page I was on. Well, actually, let me show you something first. So, we go back to the penile pathology stuff. Right, they tell you here's metastasis may be osteoblastic. Right, so you have to remember prostatic adenocarcinoma is one of those things that are osteoblastic. Breast cancer can have osteolytic metastasis. But yesterday we saw something. I'm trying to remember where it was. I think it was in the bone tumors. Let me see. I think, yeah, there was a graph with the bone tumors. This one right here. Okay, perfect. So this kind of helps you understand what you need to remember. It's also from UWorld. So bone metastasis, right? So first of all, being a 60-year-old man with some kind of cancer that most likely spread to the bones, and everything else is okay, it's most likely prostatic adenocarcinoma, and you would just go with G because the other answer choices don't really make sense per se, right? But, however, this is the little critical part that you definitely need to know. Osteoblastic lesions are done only due to 3 different things, and the other 2 are very rare. So prostate cancer, small cell lung cancer, and Hodgkin lymphoma. Prostate cancer is extremely common, okay? Everything else causes osteolytic. Multiple myeloma, non-small cell, non-Hodgkin, renal cell carcinoma, melanoma, as well as gastrointestinal and breast. Those guys have mixed, so you would see osteolytic lesions too. But if all you see are osteoblastic lesions, you definitely want to keep in mind if you see osteoblastic lesions, based on what else is given in the question, age of the patient, any other physical findings or any other lab findings, all of that is supposed to come together to tell you if osteoblastic is there, that it's one of these 3. There's only 3 guys. Everything else, generally speaking, causes osteolytic bone metastasis. It's a very easy question, just a question about what's most likely. Following a stroke, a patient is hoarse and cannot detect pinprick or cold on the left side of the face or the right side of the body. Right, and right away, as soon as you get this description, you should know exactly what the patient has. It's Wallenberg. Damage is most likely to have occurred in which of the following areas of the brain on the left? Okay, so let's go take a look at that in neurology so you can understand how you're supposed to know that, right? Because there's a mnemonic for don't pick a horse, and the patient is hoarse. Right, so let's find what we're talking about. Let's see, Wallenberg. Okay, so, right, posterior inferior cerebellar artery, that's PICA, right? And the mnemonic, don't pick a horse that can't eat, right? And the hoarseness is one of the things that's pretty unique, right? There's a couple things that are unique to each one of these, and then everything else is shared between them all. So in PICA, right, stroke, posterior inferior cerebellar artery stroke, you end up having dysphagia, hoarseness, and decreased gag reflex because of injury to the nucleus ambiguus, right? Many cranial nerves being injured in that stroke. And we talked about this in good depth with a lot of examples in my neuro videos. Okay, so our patient, very, very obvious injury to that, and then they want to know where anatomically. Right, so stroke caused by obstruction of PICA, so that's why we get into the dysphagia, hoarseness, and gag reflex. Sensation changes are due to hit of the lateral spinal thalamic tract and the spinal trigeminal nerve. Okay, so what is this saying? And here the answer was D, your lateral medulla. How would you know that? Why would you think of that? Well, they give it to you, first of all, right? It's told, it's how you learn it. But you also need to remember where the peak artery was. There's where's the picture for that? I had a picture for it. I had to remove a couple of pictures because there was no space in the book. Let's go to anatomy. Yeah, right here. We're going to start seeing where's the entire blood part. Yeah, this stuff, right? So posterior inferior cerebellar artery is down here, right? Which is obviously on the medulla. Right, the lateral medulla. Internal capsule, dorsal midbrain, base of the pons, postcentral gyrus. These are all completely irrelevant in terms of anatomy for where you actually find the blood vessel we're talking about here, your posterior inferior cerebellar artery. So if you didn't think of the artery, then you would be completely lost in knowing which part of the brain to pick and stuff like that. Studying neurology when you're doing it is very important to understand the anatomy of the brain, the anatomy of the arteries, and then knowing which cranial nerves are in proximity to each one of these arteries. Because if these arteries stop working, those cranial nerves stop working. And when those cranial nerves stop working, you get the symptoms that you see. Okay? So this is page 502. Right, it's not so bad at all. Again, NBME does a great job kind of revising everything for you. And when people don't do well in NBME, it's just a sign that you forgot a couple little things here and there. It's not the most scary thing. Don't completely panic. It just tells you what you need to revise. That's it. So you should go back and make sure, in my neuro videos, I did an amazing job making sure that I, made it very clear how to memorize all of these, how to know them, how they're going to present in questions. Right, because something has to be given to you, right? They can't give you the most vague questions on earth. So when they give you enough information, you need to be able to figure out what you're going to deduce. Now in step 1, other questions can also be like, you get the same kind of scenario, and then they'll ask you what else you might see in the patient. So you have to remember there's ipsilateral Horner syndrome, ipsilateral ataxia dysmetria, and these are all things you have to remember, because if you don't remember the entire clinical scenario, then you won't get the question right. The chances of you getting the question right decreases significantly. Here, a previously healthy 60-year-old woman is admitted to the hospital following a myocardial infarction of the right ventricle. Examination shows hepatomegaly and an accumulation of the free fluid in the peritoneal space. Which of the following mechanisms is the most likely cause of the ascites and hepatomegaly? Right, so ascites and hepatomegaly. So 60-year-old woman, myocardial infarction of the right ventricle, so she has right heart failure, right? Right heart failure does have hepatomegaly, and you also get nutmeg liver and stuff like that. Right? Which of the following mechanisms? Well, there's going to be increased central venous pressure, and that's really all there was to pick. It's not going to be any of the other answer choices. The right ventricle is primarily supplied by the right coronary artery, which also supplies the SA node and AV node, leading to loss of contractility of the right side, and thus fluid buildup, causing elevated central venous pressure. Right? Remember, you get JVD in these people also when you have right heart failure. When you have right heart failure, blood is stuck in the right heart. It's not going to go to the lung. It's going to go backwards, go back to where wherever it can. And since all of this is valveless from the right atrium all the way up to the jugular vein, you get a lot of venous pressure in that area, right? Elevated pressures in the liver and portal system would lead to hepatomegaly and free fluid accumulation in the peritoneum. Very straightforward question. The question was not about lymphatic blockage. It had nothing to do with pulmonary capillary permeability or pulmonary capillary hydrostatic pressure, or even osmotic oncotic pressure. There was nothing about protein loss. So you can't pick any of those. You can't pick A, C, D, or E. And then lymphatic blockage is also irrelevant for this patient. It's just central venous pressure. And you could think of veins because it's the right heart. The right heart is all venous blood coming back, right? The left heart is arterial blood going out to your body. See, that's why you wouldn't pick any of the capillary stuff. You're still at the venous portion of things. This one, 37-year-old woman undergoes excision of a 1 centimeter painless benign lump from the back of her neck. 7 days later, the sutured incision is erythematous and slightly warm. There is no pain or drainage. Which of the following processes best characterizes the predominant histologic appearance of the incision at this time? So she had an incision that got sutured, and now it's erythematous and warm. The warmth is just a sign of blood, right? They tell you there's no pain or draining, so she doesn't have an abscess, right? If she had an abscess, then you could think of other answer choices like D or E, but she doesn't have an abscess. She's doing okay. She's fine. She's recovering. Part of recovery is angiogenesis. A. A was the only answer choice here that was normal. The others are kind of a sign of some kind of disease, right? Infection, anything. They're not normal. They're not things that are supposed to occur with normal recovery. Angiogenesis is normal recovery, which would explain why it's erythematous and warm. Okay, and that's really all you had to pick there. This image here is just a snippet I found on Google showing you wound healing. So you have bleeding and blood clot, inflammation and scab, proliferation from fibroblasts, and then freshly healed dermis. Right, and the freshly healed dermis you can see is kind of redder. Right? It's gonna be warm too because you're gonna have some more angiogenesis in that area depending on how big the issue was. Now her thing wasn't just a wound; it's a 1 centimeter lump that had to undergo excision. So they actually cut out a big thing, bigger than what they're showing you in this little image over here. So there was definitely going to be more angiogenesis there. Okay, this was really good. So this dilated cardiomyopathy is extremely high yield, right? Super high yield. It's the only cardiomyopathy you really need to know about so much, because hypertrophic cardiomyopathy, there's only two types. There's either hypertrophic obstructive cardiomyopathy, which is inherited, and it's usually going to be a question about a young athlete that died, or you can have hypertensive, right? The hypertensive hypertrophic cardiomyopathy, where your ventricles get stronger to deal with the hypertension. That's it, right? Very simple, very straightforward. But dilated cardiomyopathy is caused by many things. So this patient is a 22-year-old woman coming to the office because of a 3-day history of non-productive cough. She also has a 1-week history of fatigue, progressive shortness of breath with exertion while lying down, and swelling of her legs and feet, all of which are signs of heart failure. She delivered a male newborn via uncomplicated vaginal delivery 1 month ago. No history of major medical illness, no medications, temperature is slightly high but nothing significant. Actually, no, it is significant. You have 99, so that's pretty significant. She has a bit of a fever. Pulse is fast, respirations are 20, blood pressure is okay. Bilateral basilar crackles are heard, which is a big giveaway. If it's bilateral special, it's a big giveaway for left heart failure, right? Because now blood is backing up into the lungs. That's why you have the basilar crackles. 1+ edema of the lower extremities bilaterally because of heart failure. Which of the following is most likely diagnosis? You look at all your answer choices, and the only answer choice that has anything to do with the heart is just B. So you just pick it. Okay. Pregnancy can cause dilated cardiomyopathy, causing systolic dysfunction. There's the ABCCDs of dilated cardiomyopathy, but there's much more than that, like hemochromatosis and whatnot, that can also cause dilated cardiomyopathy. Right here. Okay. So you look at, this is the most common cardiomyopathy, 90% of cases. Alcohol abuse, beriberi, coxsackie, cocaine, Chagas disease, doxorubicin. Then there's hemochromatosis, sarcoidosis, thyrotoxicosis, and this one, which our patient has. You might have actually read this and completely forgot you ever even saw it in the book. Peripartum cardiomyopathy. Right, very rare. It's not that common, and usually it's not a big problem because after delivery and during delivery you're at the hospital, so doctors are taking care of you. You're being seen by a cardiologist. You're what do you call it? The gynecologist. All these doctors are seeing you regularly, so everything's taken care of. And if there's any chance of you developing cardiomyopathy, that would be taken care of too. But sometimes it occurs a little later after leaving the hospital. So peripartum cardiomyopathy is one of those things that you have to keep in mind for dilated cardiomyopathy. Okay? And they gave you everything in the question. The question was very evidently showing you some level of heart problems. Okay? And none of these other answer choices are related to heart problems. Amniotic fluid embolism would go to the lung. Major depression would have been a whole different scenario. Pneumonia, again, only lungs, right? Not the heart. Pulmonary embolism, also just about the lungs, not the heart. Pulmonary fibrosis, also just about the lungs and not the heart. She wouldn't have edema from any of these other answer choices. Right? Edema occurs because of the heart failure. Also, embolisms are almost never bilateral, right? So she has bilateral lung issues, not just unilateral lung issues. 75-year-old woman has taken 12 over-the-counter NSAIDs daily for the past 2 weeks for mild osteoarthritis of the neck. And that's already, like, before you even read the question, you should know this is going to be a question about renal injury. Which of the following is most likely to be increased in this patient? So if you're going to have renal injury, remember what NSAIDs do. We just talked about it, right? The PDA, prostaglandins dilate the afferent arteriole, bringing more blood into the glomerulus. You take NSAIDs, you prevent the PDA, so you prevent dilation of the afferent arteriole, decreasing how much blood is coming into the glomerulus. Plasma renin activity is going to be the only thing here that would increase, right? Because B is the thing you're decreasing. You decrease renal blood flow, and anytime you decrease renal blood flow, you increase plasma renin activity. That's how renin works, right? You're not going to increase urine prostaglandin excretion, right? E2 or thromboxane excretion, and you definitely will not increase glomerular filtration rate. You're going to decrease that too, because you're decreasing how much blood is even coming into the glomerulus. Right, very straightforward question. Okay, yeah, this one. If you did microbiology at least twice and you did sketchy micro, you should be perfectly okay with most microbiology questions NBME throws at you. And microbiology is definitely a high yield topic on NBME. 5-year-old boy who lives on a farm has had diarrhea, cramping, abdominal pain, and fever for 2 days. He drinks unpasteurized milk. An organism is isolated from the stool and it grows at 4 degrees Celsius. Which of the following is the most likely causal organism? So if it grows in the cold, that already comes down to only a couple answer choices that you could really pick from. And Yersinia enterocolitica, right? Remember it like that. Enterocolitica is the go-to answer choice from here. The only other thing that we think of with cold temperatures is Listeria, right? And that's not really an answer choice here. Okay, so again, and also Listeria, you usually think of infecting a pregnant mother or a very old man, not necessarily, diarrhea in a baby per se, but it can cause that too. So let's take a look at Yersinia. The image for Yersinia with the buboes and stuff also does a good job to help you remember that it's cold outside. Right? So this is Yersinia enterocolitica, and you can see, if I make the picture bigger, that it's cold outside. There's ice on the windows there. Okay, Yersinia enterocolitica, and this is the baby drinking the milk, which would be unpasteurized. All right, so not so bad. Listeria is also the other guy. So let's take a look at Listeria real quick with the cold and Listeria. Right here. Right, so Listeria is occurring in Christmas, which is a winter thing, right here. Right, you can see with the icicles outside. Right, it can cause meningitis in a baby. It can cause many things in a mom, and it can also cause meningitis in the elderly. Which is why if you have an elderly patient presenting with meningitis, before you even find out what's causing it, you treat them with everything they could possibly need. And that includes giving them ampicillin. That's why you have the amp here, just in case it's Listeria meningitis. But you would also give them everything else that you can possibly use to treat any other kind of meningitis. And those are the things that are discussed very well in systems, right? When you go to microbiology systems, this is where the microbiology starts becoming much more clinically relevant, right? Much more clinically relevant. You start seeing, because when you get a question on pneumonia, heck, all of these guys are answer choices. All of these guys are answer. You can actually get J to K answer choices, and all of these are going to be answer choices. So picking the right one really depends on what group they fall under and what age they fall under, right? Once you match that, you can pick the correct bacteria. And of course, if they give you anything else about bacterial features, right? Common causes of meningitis, same thing, all of these guys. So anytime you have someone coming in, right, remember, give ceftriaxone, give vancomycin, and also add ampicillin if Listeria is even remotely a possibility. Because you got to treat all of these things. Then you take their blood, check them out, see what's wrong, and then pick the correct antibiotic based off of exactly what's causing their meningitis. But you don't wait for labs to come back, because in that time more damage is going to occur. So not so bad. Yersinia enterocolitica. You know enough about some of these others that you can just knock them out. And diarrhea, cramping, and abdominal pain for 2 days because of drinking milk is not E. coli. Right? E. coli is more about burgers. Helicobacter pylori, irrelevant here. Salmonella, not exactly related to the cold temperatures at all. So very important to remember just general features of all these bugs, because that's just what the test is about. 119, 45-year-old man with Lipheromany syndrome agrees to participate in an investigational study of tumor suppressor gene disorders. A mutation is found in his p53 tumor suppressor gene that converts an arginine to a proline at amino acid position 248. This change alters hydrogen bonding between the mutant p53 and the thymidine, oxygen, and adenine ring nitrogen of DNA. They're really trying hard to intimidate you, right? That's the main point here. They're really trying hard to intimidate you, because how does intimidation occur from reading? When you're reading things that you can't visualize and can't relate to something you might have read before, it's intimidating. And you've probably never read this shit before. But it's okay. Don't get intimidated. Just read it for what it is and understand whatever you can understand. So basically, what did I understand? There's a bad bonding. Just bad hydrogen bonding because of the mutation. Which of the following is the most likely result of this mutation on the transcription of genes that inhibit cell division and contain the consensus sequence of all of this at 30 base pairs 5' to the transcription start site? Okay, so if you have a mutation that inhibits transcription of these guys, the TATA box, right, upstream from the transcription start site, then you're going to have decreased binding of RNA polymerase, not DNA polymerase, RNA polymerase, because you're doing transcription. You're polymerizing new RNA. No TATA box promoter, decreased binding of RNA polymerase. That's it. They were just going to test you on this basic concept, and they made up a really interesting story where they started with the disease that you might not remember. Then they went on to talking about really biochemical and genetic things to really intimidate you, really, wear down your brain, and then you come down to the answer choices, and you might have actually gotten so worn out that you were like DNA polymerase or RNA polymerase. I'm not sure. Well, the difference between the two is vast, right? They're very different guys. They do completely different things. There was no reason here to pick DNA polymerase if you're talking about transcription, right? Transcription is for proteins. Proteins, RNA polymerase, right? So very important to know that. Other than that, there's really nothing else to worry about. Okay, so last question for this video. 79-year-old man is brought to the emergency department by his wife 30 minutes after he lost consciousness for 30 seconds. Alright, so that's a lot of 30s there, but he lost consciousness for 30 seconds, and he's very old. On arrival, he is alert, but he says that he's dizzy. There's no urinary or fecal incontinence, pulse is 40 per minute and regular, blood pressure is low, physical exam shows no evidence of tongue biting, right, which can occur if he had a seizure. The lungs are clear to auscultation. Cardiac exam shows a variable intensity S1. He's oriented to person, place, and time. ECG shows AV block, 3rd degree. Which of the following is the most appropriate next step in management? Well, if he has a 3rd degree AV block, right, the only thing you can do now is give him the catheter, right? Insertion of a pulmonary wait, no. Why did I put C? Give him the pacemaker, right? D. Yeah, my bad. I keep putting the wrong letters sometimes. The only thing you can do is give him a pacemaker, right? There's no reason to put anything else. A transvenous pacemaker. You would read the answer choice and you would know immediately, right? Whatever happened to this guy happened because he had some level of some type of fibrillation almost, right? And he could have died. Thank God he didn't. We want to make sure we want to make sure this doesn't occur again. They gave you everything you needed to know. They gave you the diagnosis from the ECG. When you get a 3rd degree AV block, you have to put the pacemaker there. It's the only way to make sure that pace is maintained. Alright, so let's take a look at 3rd degree AV block. And AV block in general, there's a lot there to memorize because it can present in very interesting manners. So let's see. Where do they talk about it? Wasn't it? Oh, it's under physio actually, right? Yeah, right here. Okay. So ECG tracings, right? AV block. 1st degree AV block is okay. There's really not a big problem there. All your PRs are equal, okay, but it's a little prolonged, right? Then 2nd degree AV block, which is most commonly tested, has 2 different types. There's type 1 and type 2. In type 1 has 1 dropped QRS. That's how you want to remember that. Type 1 has 1 dropped QRS. You get a dropped QRS. And the way the QRS drops is because the PR keeps increasing, right? 1 drop QRS as the PR lengthens. Think of finding the one you love, falling more and more in love with them, which is longer PR, and suddenly skipping a beat due to the affection. That's something I made up when I was studying. So you fall more and more in love until you finally fall in love and your heart skips a beat. Right, so skip the QRS. Type 2, Mobus type 2. Type 2 has 2 equivalent PR intervals that lead to a missing QRS. And that's how you want to memorize that. You see, your PRs are all equal. The PR is not going to be increasing in size, and then you're suddenly missing a QRS, right? Drop beats that are not preceded by a change in the length of PR interval, which is what you see in type 1. In type 1, you have a drop beat preceded by changing in PR length. Okay, so type 1 and type 2. And the third degree AV block, the atria and ventricles are beating independently of each other. So now on the ECG, you see P waves and QRS complexes that are not rhythmically associated. Sometimes you even have a P wave on the QRS complex because it's occurring together. Right? And that's going to mess up everything. Treat that with a pacemaker and you're done. Right? Really straightforward. So that was just transvenous pacemaker. Nothing else to pick here. No echo is going to be necessary. Why would you do an echo now? You already did the ECG. You're done with that part. An echo won't tell you anything new. Angioplasty or stent placement is not really the treatment for AV block. Alright, so we'll stop here, and then in the next video we'll continue on and we'll finish up another 20 questions of NBME 22. Thank you very much for joining. Keep studying hard, and I'll see you guys again very soon.